Let's move to Amritsar. Arun Chopra.
Amritsar. You go to Amritsar.
Yeah, fine. We can see Amritsar now.
That's a golden temple there.
Yes. Good. Thank you. We all got the blessings of the Golden Temple.
Arun, we are with you.
Oh, great. Good
Uh,
evening. Greetings from Amritsar. Can you show us the slides, please?
Yeah, please introduce your
Okay.
team and yeah.
Ah,
the team.
yes. So, first, you should meet my colleague. This is Dr. Arjun Ved Gupta. He's my colleague in the department. This is Sister Sukhjinder. We have our technicians, Digambar, Rajiv, and we have Nikhil and Ritika from Abbott here. So today, the case that actually we were planning to show was a case which highlighted more FFR and OCT as well. But because the patient wasn't keen for, this sort of recording, we had to postpone and take another case. So this is a patient. Please show the slides. This is a patient who presented yesterday. He had 2 days history of chest pain, acute inferior MI with post-MI angina, good LV function. Angio showed double vessel disease. So RCA was the culprit lesion. I'll just show you the runs. Digambar, RCA ke shot दिखाओ. So the RCA had a moderate lesion. Then after bifurcation, the PD was totally occluded. And we did this yesterday. Show the final result. So I hope you can see the images.
Yeah, we can see.
Sure. I'll just show you the end result on that. Okay, so RCA opened up well, good sized PD distally, and with a good result. So today, now let's go to today's scenes. So today we've taken him up for the other lesion. So he has mild plaques, mild disease in the left main, distal left main. He has a significant osteal stenosis of the circumflex and a lesion in the OM1. There is a small ramus also which has disease, but which we'll not be touching today. Next scene, please. Next. So the LAD appears normal here. There is a mild lesion in the LAD after the diagonal. So we did next an OCT run here, and we can share the OCT images. So what we found was that LAD is a small vessel, about 2.4 millimeter distally, and there is no area of significant disease. The MLA at the point where we can see the narrowing is 2.3. So we did an FFR in this vessel also, and the FFR was 0.82. The left main has mild disease, as you can see here in this cranial view. The MLA of the left main is 7.4. So the decision was that we don't need to probably touch the left main and the LAD. And the plan is to tackle the circumflex. So you can see the images of the LAD.
Yeah, we can see the OCT.
Oh, sorry. This is the LCX. This is the LCX. No, okay, you can show the LCX also.
Okay.
But we would like to see the LAD. Okay, just show the circumflex. So circumflex is obviously a tight lesion. 1.3 was the MLA here. And left main has some disease, but not significant. The maximum...
Can you freeze at the point of osteal circumflex?
Sure. Please show us the ostium of the circumflex.
And just the 5 millimeter segment there. I don't think we saw any calcium over there. It was more of lipid pool.
Yes, that's right.
Fibrolipid, yeah. No, that would be an important point. Yes, if you can just show that.
Volume बढ़वाना. I hope my voice is audible clearly.
Yeah,
because-
your voice is audible.
Ah, yes, okay, now I am
Yeah,
hearing
please
also
go a
well.
bit distal.
Yeah,
Bit
yes.
distal.
Bit distal than this.
Yeah.
So the total diseased segment is about 18.5 millimeter here, and the reference vessel diameter is 2.75.
Would
And
you-
Arun, actually, you have a disease, OM was there, Did you do
yes,
an,
there is a disease in the osteum of the OM as well, which
okay.
I am planning to keep provisional. I have wired it, and I am planning to keep that provisional. So LED, let's see the LED run also, because I just wanted to do OCT and FFR in the LED to make sure that we don't need to touch the LED. So let's just see the OCT of the LED.
Yeah, I think you already showed that, right?
You showed
You
the-
showed
No,
that
that we
lady.
showed, this is LED.
Yeah.
0.82 is the FFR you told, right?
Yes, 0.82 is the
Now, we
FFR.
remember all these.
Who-
things.
yeah. So
we
would you do
accept-
the FFR of circumflex as well?
Yeah.
Oh, I didn't do that. We can do that if you wish so, but I thought that was a pretty significant lesion both angiographically or as well as on OCT.
No,
Yeah,
if you
I'm
do
a-
the pullback, maybe we will come to know where is the absolute stenosis. So the reason why is that we have been listening to lectures since morning about ostium circumflex, and everybody agrees that that's the Achilles heel. And by
Right.
and large, if you try to nail the ostium of the circumflex, many a times we are not going to fix it properly
Right.
and may land up in the left main.
Sure.
So if we can get away with a drug-eluting balloon-like picture, then nothing like it.
That's right.
Right. So that
And
is
in
what.
your case, there is
Mhm.
no
He
calcium.
became a
It
proponent.
is all fibrofatty.
Arun, actually,
Yes.
don't hear him only because he is becoming actually a proponent of drug-eluting balloon.
Next.
You actually think that it is actually,
No,
you have the
next,
landing
slide.
zone of the stent 1 or 2 millimeter away from the ostium. You can
Yeah.
actually think it over. That is what you are definitely looking
So
into.
that was the FFR of the LED, and
0.8.
I'll show you. This is what I had decided actually. Just as you are saying, there are three possible strategies which we could use here. And one is, of course, try to do an osteal stenting of the circumflex and keep the OM provisional. Second strategy is to stent from left main to the circumflex, make it very complex, because there is a lot of disparity between the left main size and the size of the circumflex. And the third option is balloon dilatation followed by drug-eluting balloon.
If
So,
in that
what would be your choice?
see Arun Chopra, it's second choice definitely not in my picture.
Agreed.
The first one is okay, the third one is okay. If at all
Right.
I'm doing a third one, I will use a cutting balloon.
He did that.
Pre
That's what he's saying. Cutting balloon angioplasty.
Followed by
But drug-eluting
DEB.
balloon.
or cutting balloon. Actually, you told balloon. That
Yes,
is why.
CT.
Oh, yes.
Cutting balloon, then
Cutting
followed
balloon.
by a DEB is actually the best option. That is for.
But I think since you have FFR on your table, you should
Right.
use that as well.
So
If
Okay.
you are going to do only balloon angioplasty, before you open a drug-eluting balloon.
I agree with you. I think that's what I would do. I would have done actually an FFR first, followed by the value, then OCT. But
Absolutely.
now if you want to do an FFR, you have to abide by the rule that in case if it is negative 0.81,
Yeah.
you're ready to walk away.
No,
Yeah,
that
that
means should we do DEB
There
or
is no
not?
doubt about it.
Because-
Once you do an FFR, you should be definitely go with the FFR. Otherwise, why do you do an FFR?
No, the point is that we've done a balloon dilatation of the circosteum already.
Oh, you have already done.
So, yes, I didn't know how much time we will have. I thought we may get just half an hour. We may not have
So-
time to do
So
everything.
was it cutting balloon or plain
No,
balloon?
no. As of now, I have used a routine 2.5 millimeter balloon, a non-compliant balloon, which opened up well. But I have a cutting balloon and DEB ready as a strategy if the house feels that that is what we should do.
Okay, so
Okay, now I-
now
I
we are
think-
committed, but even now I think it's not too late to do FFR. If FFR is okay, just do drug-eluting balloon.
What I am thinking is we
Why
can
not?
do FFR, and if FFR is decent, then we can do a drug-eluting balloon and leave.
Yes. Then
You
now
agree
you can
with
do
that?
a
That's a reasonable option?
Yes.
Yes,
Okay. Okay,
Let
then
us
we'll
see
do
that.
that. So maybe you can visit one of the other centers for 10 minutes while we do all this.
She has a question.
Right. Okay.
No, but
Yes, sir. I think once we have already balloon dilated, there's no point in doing FFR now. If we had to do it, we had to do it before balloon dilatation. Now, I think the option, since it looks like a very small vessel, see, we have to undersize circumflex. If
Right.
the LAD was 2.4 distally, this definitely looks less than 2.5, not more than that.
The,
So I think drug-eluting balloon would be, if at all we want to do something, it would be drug-eluting balloon rather than stenting or any other thing.
I tend to agree, and that's why that is my final choice. This is what I would like to do. What I had thought was I'll do cutting balloon, then drug-eluting balloon, and follow it up with OCT or FFR.
Yes, that sounds very good,
Okay,
Dr. Arun
okay,
Chopra.
fine.
We'll come back to you after going to the
Okay, great.
center.
See you then in another 15-20 minutes.
Mumbai.
Right. Okay.
Thank you.
Thank you.
Can we go with Dr. Arun Chopra at Amritsar, please? We
Ji,
only
hi,
have 15
waiting.
minutes for both of them. 13
Sure.
minutes.
Oh, we are ready. आगे चलो. वो ऊपर चलो. Hi, this is Arun.
Hi, Arun. Ramesh Dagubati. So show
Oh,
us
hi.
what you have done.
So we, as planned, we started with a cutting balloon and made life
Size.
slightly difficult for us. So the vessel was 2.75 distally and 3 millimeter at the ostium. So we took a 2.75 Wolverine cutting balloon next. So went up to 10 atmosphere because there was this small, edge persisting next. But after that, we got this.
So option number one.
Yes, so then I didn't have much choice. So we changed the plan to a stent. So go on.
no, that was your first option,
Yeah.
No, that was not.
Arun,
That
actually,
was
you're
my
correct,
second option.
You are correct in choosing the first option. Second
No,
option.
no, I
like-
would not have minded, the DEB. I would have actually liked to do that. I had the DEB
Second
out.
third option is given only because of VT Shaw. Your option was the best option. Second option, nobody liked.
So we stented with a 2.75 28 designs, and then there was this flap in the OM1. So I recrossed into this is the pot with a 3 millimeter balloon, 3x8, then recrossed into the recrossed into the obtuse marginal, parked a wire in the LED, parked a did balloon dilatation of this OM, did a kissing balloon of both. I'll show you all these. So we did a kissing balloon here and then did an OCT. So this is now you can see that circumflex has opened up well. LED appears fine. The OM1 has a small flap but with excellent flows. And now we've done an OCT run, and I'll just show you the OCT run on this. Please show the OCT. Okay. So the OCT shows a well-opposed, well-deployed stent, and the ostium is covered. There is the next run. There is about 1.4 millimeter of the stent in the left main, and it appears to be good. So please have a look at this and tell me what does the house feel about whether they are happy with the result.
Actually, in these situations, Ramesh, will you put a wire into the LED and putting an OCT? It will be difficult because you may create a lot of problems there. So what will you do actually with the LED thing? Saurav, any opinion for you? If you have a stent is extending from the circumflex to the LMCA, will you do any imaging into the LEDs? Actually, will create more problem, right?
Yeah, so I think both of these cases highlight the points that we were making first. Number one, it's just hard to nail the ostium precisely. So you always should have safety on your mind that stents don't always land where you want them to. And it's good to protect often. The second piece is that if the flow is good and if it's just 1.5 millimeter stent, then I don't always necessarily cross over an image into that. But on the other hand, if the ostium looks hazy, if I have any evidence of plaque shift, then I have a very low threshold for just imaging down there.
So at one point, actually, you are telling LED stenting is okay, crossover is okay. In a circumflex osteal lesion, will you do a crossover from the LMCA to circ and keep the LED osteal pinching and all, creating confusions? Number one. Number two, actually what we have done is actually he put a stent he has done a balloon dilatation prior to the cutting balloon. Did it create more dissection rather than the cutting balloon alone done would have been better? This is my question.
I'm not sure that I can tell prospective or retrospectively. Of course, it's easy. Prospectively, I'm not really sure. I think it was a reasonable strategy.
Ramesh, what is your opinion?
I mean, I think there's more chances of dissection with the NC. If you're going to go with cutting, I would just go with the cutting balloon and then see. If the stent struts, the first question that you asked me, are hanging into the left main, you have to open up the stent strut into the LAD. That's what I believe, because the LAD is definitely much bigger vessel than these circumflex.
1.4 millimeters into the LMCA. You put a wire. You are thinking that the wire will go beyond the stent strut. Then you are actually going to compress the stent strut into the circumflex and creating some more luminal loss in the circumflex rather than. And if you exactly go through the wire in the 1.4 strut, I don't think it will be easy to take a wire, and I don't think Ramesh can do that.
It's definitely not. That's why the number one, I think, is prevention is always better than cure or trying to struggle.
Yeah.
We could have just actually either tried to leave it, prolonged balloon inflation.
You only told that I will be opening that stent strut. That's what I might coincide. You are
cut the
1.4
stent
millimeters
back a little
extending
more,
to the
and then it'd
LMCA.
be a lot simpler.
Yeah, CA strut.
Anyway, Dr. Pratap, what about our case here? Let's first discuss this out.
Leave it.
About what
No.
next?
So, can you show us the ostium of the circumflex
On the
polygon where
Yes, please.
some struts are seen in the left?
Sure, sure. I'll just show that to you. You can see the whole run now.
Sir,
So-
I ask a question?
More than the struts hanging, I want that the under expansion is not
We take
there.
some
mal
question from the
apposition is not
crowd,
there.
you know.
Actually,
Oh,
we have seen in this
Stop
case.
here. Yes.
1 minute, Manish.
yes.
Let us see the strut and then come back to you.
So here it seems that it's definitely across the struts and a bit more. I mean, I would.
Yeah, there. You can see.
One image.
You told
See the red
1.4
dot.
millimeters.
See the mala position there at 4 to 6. Go
Yes.
back.
Yes,
Go
yes.
to
Go
6.
back. Go back. Yes.
Yeah,
Yeah.
see there. So I think that should not happen.
Okay.
That's the circ ostium.
Okay. So
If
what do
few
you
struts
suggest?
are hanging is still acceptable, but under expansion or
It's like
mala
a figure of
position
eight. Is a
is-
circumflex LED ostium or not? That part. There is a 1 or 2 strut is actually not opposing very well. That is correct. Yeah, LED is
No,
coming in.
No, but that's on the opposite side. I am saying from here 3 to 5.
That's the carina. I mean,
From
you can
3
clearly
to
see-
5, I'm saying.
But
I'm not worried about those struts there.
that's the,
Yeah, it's mala
Well, let
position.
us see.
that's the carina right there. You can see the wire from the.
No,
That is what?
on the
From 3 to
left.
5 is not the carina.
No, you can see the LED wire and the LED coming in on the
The
left
LED
side.
wire is at 9 o'clock.
I know, and that's the carina where you see both the LED and the circ together.
That is what I also thought.
Back, go back,
That's the definition of a carina, when you can see the LED
go
and the
back
circ
a
together.
bit at the circ ostium proper.
No, it looked like a
1
figure
millimeter.
of eight and seeing a carina. There is,
Let's see
I don't
the
know.
area there. Let's see the area there. Yeah,
Okay.
okay.
Go
So this is just the
proximal,
circ
proximal,
ostium.
go proximal.
Go proximal.
This part,
Okay,
actually,
stop.
the ostium is coming up.
Stop here.
Stop here. This is exactly the figure of eight coming. Already
Yeah.
the LED came there.
Yeah.
So Ajay, you're saying that at the carina, obviously you cannot have a complete apposition because the stent is just not that
Yes.
big enough.
It's
Yeah, I mean,
basically
Yeah,
a bit
because
hanging
the
there.
struts are hanging back, and anything you try to do there is going to impact. But what's nice here is you clearly see LED and circumflex, and of course you're going to have struts that are unopposed right there because that's the definition
Right.
of a carina.
So Ajay, what do you think? You just leave it,
I
right?
would leave it. I would leave it.
So
mean,
I would
correct.
also
I
think
mean, I
to
want to
leave
measure
it.
it. You can measure the ostium of the circumflex true and see what the measurement looks like, but overall the expansion.
What's
looks
the area here?
bifurcation of
The
ulna
circumflex
looks
ostium?
great. And then see.
Yeah. One frame
Okay,
up.
circ ostium is 5.62.
To be accepted because it is actually not a large vessel. That was
Yes,
the
it's
first comment. That was the first comment we made. Since it is not a large vessel, we will go with a drug-eluting balloon. You got a 5.6 area in the large, small vessel with 2.75. It's okay. I think it
So
is
Dr. Arun Chopra, majority of the vote is to leave it alone now and show
And
us the final
actually,
answer.
Arun, we
Okay, I would also, this is my view
support
also,
you.
and I am
Support
glad
you.
that
We are
you all
confused.
feel the same way.
We are all supporting you because we have seen the golden temple.
Ravi, Pratap, let him talk.
Because because you've been to the Golden Temple. Okay, that was a good one. Great, thanks.
So-
Okay, so I'll just take one shot here to see how things look.
The LED cordon. We can't see the,
Sorry.
yeah.
So are you happy with the result?
Can I have a question, sir?
You know it better at the LED ostium. What is it? Is it anything?
I don't think so. It seems to
Yeah,
be very
take an
clean.
LEO caudal and
I
show.
can take another view. Epicaudal, alveocaudal कर लो.
So before
I'll take another view. थोड़ा caudal और बढ़ाओ. LED बढ़ाओ, alveo बढ़ाओ.
So let us to look at this angio and then Manish has a question. That looks good.
So Ramesh, would you still cross over into the LED and dilate the stent stretch? Let me ask your opinion. I know you're
Okay.
hesitating.
So what do you think now?
I don't like actually anything hanging. Okay, I think that we are saying that it is good. Majority wins. And
So we pull out the wires, take final shots and come
Yes.
out.
yes,
Yeah.
please.
I think that's the consensus
Yeah.
opinion.
Actually, you are having a lot of support from the audience telling them not to do. Only few people are against, and VT you don't hear actually. He will make you more complicated, you know.
Manish has a question or?
Yes.
Sure.
Sir, in this case, we have seen one stent
Alleo
was
cranial.
placed, from the ostium of the LCA.
Are you
final,
caudal?
KBI was done to open the side struts of the OM. But the earlier case, which in the when the LED stent was placed from the ostium,
Are you
the final
thoda sa
KBI was not done to open the early diagonal. So what is your standard practice whether final KBI should be done when major side branch is coming out of our side single strand when we are putting the crossover strand across a major
Okay,
side branch,
so
which is more than 2.5 millimeter. So final KBI should be done or it should not be done.
1 minute. Actually, Arun, thank you very much, Arun Chopra. We will
okay, I
actually give
think
a good clap.
we'll
Thank you
pull
very
out here.
much.
Thank you. Thanks a
Thank you.
lot
Bye.
to TCT India, to the organizers, and to all of you for being with us. Thank you very much.
yeah, thank you. Yeah. So
Actually-
now
Actually, Arun, do you want to tell a learning point of this case? One point.
Oh, I agree that if I think one point is, of course, that if it had not been circ ostium, if it had been LED, I would have gone directly with the cutting balloon. I would not have gone with the NC balloon first, and I would have tried to go with the cutting balloon in the first place, and that may have been a better strategy. But sometimes cutting balloon is hard to negotiate, especially with two wires there. There was a wire in the OM as well. So I thought I'll just create a small space there before going in. So one, I would say learning point is that cutting balloon, if it is the strategy, should be the first strategy and not a fallback strategy.
I will actually, Arun, one point I just wanted to emphasize here. If you use
Sorry,
a
please.
cutting balloon into the circumflex where you have a tough angulation, take a 6 millimeter, not a 10 millimeter. 6 millimeter cutting balloon definitely will cross easier than a 10 millimeter. People try to take a 10 millimeter. That is one reason that your cutting balloon may not cross.
Yeah.
That is what is.
Okay.
Thank you,
Okay.
Dr. Chopra, and to your team, a fantastic demonstration of this complex PCI with the FFR and OCT guidance.
Thank you. Thank you very much.
Go to
thank
the-
you.
We'll
Thank
move
you.
on. We'll move to the first site.
And actually, Ramesh should answer. Manish asked a question to you.
Thank you.
Anil Putta.
He asked a question. You have to answer the question. He told why some people are doing a opening of the strut and some diagonal, he opened up the strut.
So
Here,
final
nobody.
kissing balloon was just not studied in two things. Nordic trial did not show any benefit of, that's how you can look at it. The event rates are same with the FKB or not.
Can you switch over?
And COBIS 3 registry looked at final kissing balloon, and finally their conclusion is that there is no loss. You're not actually losing anything by doing a final kissing balloon. So with these two studies, I think it's now we are in, whether you like to do it, you can go ahead and do it. There's no loss, no harm that is done with final kissing
No
balloon.
gain, no gain, no pain.
Sir, same should follow with the when we are putting the allotment to the LED crossover stand, and we should not do the final kissing to open the LCF side branch. Same strategy. Should we do the final KBI when we are putting single crossover stand from allotment to LED? And LCF is also major vessel. So should we open the struts by doing the final KBI or not?
Manish, one point is very clear. In double stent strategy, there is no question KBI is required. Provisional stenting strategy, if there is a flow reduction is there, you have to do a KBI. Otherwise, people actually try, depends upon their chance of crossing over. If you cross over, if you do a balloon dilatation, finally you have to do a kissing. If you don't do a balloon dilatation, only keeping a wire, you get a T3 flow. Just leave it.
Okay, sir. Thank you.